my name is Julia Ondarza. I am a neurocritical care physician assistant at Stanford in California. A little bit about my PA journey. I went to undergrad at Texas A&M and knew I wanted to be a PA. Was doing all my pre-PA prerequisites and then also simultaneously doing some medical assistant volunteering in oncology, and then after that I was a medical assistant in orthopedic surgery office. I attended UTRGV PA school and graduated in 2019. I became a certified PA in March of 2020. So my field of medicine, I actually knew I wanted to do a hospital setting job while I was a PA student going through rotations. I fell into critical care because of the demand during the pandemic, and I started off at a community hospital where we saw a little bit of everything. I worked in a surgical trauma ICU, a neuro ICU, a cardiovascular ICU, and medical ICU at 4 different hospitals. I did that for about a year and a half and then decided I want to specialize. I got hired on specifically for the Neuro ICU at Stanford last December. What a typical day consists of? Well, my schedule is 3 days a week, 12-hour shifts, and we rotate between 1 month of days and 1 month of nights. For day shift, I will arrive at 6:30 a.m. I will look at my assigned patients for that day, which our patients are split up between usually 4 APPs, or 2 APPs and 2 residents, and I will have anywhere from 3 to 6 patients a day. I will get report from the shift before. I will do pre-rounding, meaning I will do chart reviewing, I will go examine the patient myself, and then I will prepare my oral presentation for rounds. Before rounds, I actually love, we do like a 30-minute team meeting, and this can be an interprofessional meeting with, say, the neurosurgeons or the stroke team, but what I love about this is the attendings will do a chalk talk. It's like a 5-minute or to 10-minute opportunity for the fellows and attendings to teach us anything on the dry erase board, and that's my favorite thing about working at a teaching hospital is the moments of education and just learning from the brightest minds. So that all takes place before rounds, and then we'll spend about 3 to 4 hours on rounds going and seeing each patient together as a team, meaning residents, APPs, fellows, attendings. We're all together, seeing each patient together, and then coming up with a team plan, so a management and treatment plan for this patient. After that, in the afternoon, we'll do any admins, any consults, and then this is the time for procedures and bedside ultrasounds, which we all love doing in the afternoon. And then, of course, writing the progress notes will usually take quite a while. Something I learned is my progress notes in a teaching hospital are a lot more verbose, but I enjoy it. I love putting my rationale behind a good progress note. So what type of cases we see in the Neuro ICU? We see strokes, hemorrhages, TBIs, encephalitis, meningitis. We do brain death exams. We see neuromuscular emergencies such as like Guillain-Barré or ALS. An interesting case that I think would be great to share is we had a gentleman in a different part of the hospital, not even in the ICU, who was admitted for an NSTEMI and had gone to cath lab to receive a stent to the LAD. Procedure went well, was neurologically intact afterwards. However, several hours later, the nurses started to notice that he was agitated. They tried some medication for that, and it wasn't until this patient actually tried to go and walk to the bathroom that they noticed that he had some focal neurological deficits, that he had some left lower extremity weakness. they decided to call our team to come evaluate. We noticed that he not only had some lower extremity weakness, but he also had some confusion and I believe some difficulty speaking. But it's hard to know if it's from the medication that they gave him. The primary doctor on the case was very concerned about a stroke and was very ready to pull the trigger on the TPA. But I saw the patient and he had a history of TIAs. We also wanted to get him to imaging to see if there was any occlusions. And what happened was he ended up not having any signs of any large vessel occlusions on imaging. We ended up not doing TPA, and my resident actually corrected my differential diagnoses. He said, what about contrast-induced encephalopathy? Which is not something I really remembered learning about, but I kind of looked more into it, and given his history, he had never received contrast prior to that morning, we decided to just observe him in the Neuro ICU. This patient ended up recovering within 48 hours, and it ended up being more suspicious for an idiopathic contrast-induced encephalopathy that was transient. So the reason I share this is because I don't remember learning about that in PA school, and there's going to be a lot of situations like that happen when you are a new grad. And something that is shown to be learned is that an exam is important. So just because a patient is admitted for something completely different, the heart, an NSTEMI, you don't want to forget to do a good neuro exam. You don't want to chalk it up. You don't ever want to chalk agitation up. You need to rule out everything else before you're going to sedate a patient due to agitation. You do a good exam. I had to take a good history, and of course it was very important that I knew that he had that procedure done that morning, and then keep a broad differential, and then to always bounce clinical decisions such as giving TPA off of more of your senior team members. So for my first birthday that I had while being a PA, I decided it was just a 28th birthday. There was no reason to do it big, but I wanted to rent a beachfront condo in San Diego and invite all of my friends out. And then we also rented a yacht, but I didn't pay for everything. But I would never have been able to afford any of that as a PA student. So my mindset with money is obviously save it, apply it to loans, but then also at least once a year I try to take a really memorable trip with friends or family. The ICU is amazing, rewarding, complex, tragic, frustrating. There's definitely a lot of resuscitations, but there's a lot of deaths. And a big part of my job is having the end of life discussions with families and with patients themselves. So I think the most gratifying job is being able to be there on the worst day of a patient and a family's life, to help instill trust and to help guide them through really difficult decisions. There's times where I had a casual conversation with a patient about what they ate, or maybe just they were telling me about their grandson or dog, and that ended up being the last conversation that person ever had in their life. So I take that extremely seriously, that every single day, no matter what day I'm having, I try to make sure my bedside manner is first and foremost at the highest expectations, is the same as my clinical knowledge. This goes for first years and second years. Do not compare yourself to the students beside you. As a first year, don't compare your grades. As a second year, don't compare your rotations. Just because you aren't as hands-on in a rotation as you wanted or as your roommate is, does not mean that you can't get extremely valuable experiences from this rotation. What your second year is for is you're finally seeing how everything that you learned in your first year is applied. You're also learning how different clinical, either clinicals or hospitals, are using PAs. I mean, something that's very unique to the PA profession is how diverse our job is. I've seen PAs have a ton of autonomy, and I had a ton of autonomy in Nevada, whereas sometimes I've seen people who have jobs as a PA where they're essentially used as a scribe. So your exposure that you're getting on a rotation, just seeing how the ropes and the workflow and just the interactions between clinicians and patients is extremely valuable. And I highly advise for you to write down any clinical scenarios that stood out to you or impacted you, because when it comes around to interviewing, you're going to need examples of times where you were stressed or overwhelmed, and then how you overcame that, or how you overcame and prioritized multitasking, or maybe a communication issue with a patient or a colleague. What was that, and how was that resolved? Those are the types of things that are really going to impact your interviewing in your first job. Not if you intubated once or did a lot of pap smears. All of that you're not expected to be proficient in as a new grad. And in my case, going into critical care as a new grad, I was highly trained to do that. Actually, at hospitals, you don't get what they call privileges to just go around and do procedures because you graduated PA school. They actually require you to do a certain amount of supervised procedures and then apply for privileges, and you have to prove you are competent at something. So just don't worry about your rotations. They're not as important as you think they are. I remember freaking out because I felt like all I did was observe in one, and that actually ended up being one that I drew a lot of experiences for that I brought up in my interviews. So hang in there, stay positive, enjoy the safe learning environment that you're in. Always ask questions if you're unsure or if you don't feel comfortable doing something, and you're almost there. You will be here before you know it. I feel like I was sitting in your seat literally yesterday. Thanks, guys. Take care, and don't feel free to reach out. I do a lot of mentoring for students and new grads. I'm really involved with the PA class at Stanford. I actually do their neuro module lectures for them. So I'll pass my email on. Bye, guys.